For our study, which is a phase 2 study that evaluates the combination of biological doublet, lenalidomide plus rituximab, we designed two treatment phases, which I think is rather unique in this frontline setting. We start with an induction phase, which included lenalidomide, given at standard schedule, which is 21 days on, 1 week off. So each cycle would consist of 28 days. Patients started at a dose of 20 milligram, but they have the option of dose escalating to 25 milligram if tolerated. In conjunction, we started also with rituximab infusion. Initially was a weekly dose for 4 doses total during cycle number 1, and subsequently they would be on a regular schedule of every 2 months. So in the induction phase, which runs for about 12 cycles, they would receive a total of 9 treatment of rituximab. That's in conjunction with the pill. It's rather convenient and easy. Obviously, it's outpatient-based regimen. For those patients who responded, we would provide a maintenance phase, which I think is rather novel for the design. And at those for those patients, they would be given lenalidomide at a lower dose, 15 milligram daily, 3 weeks on, 1 week off, and they would be continue with rituximab maintenance as well. And it's pretty standard schedule, once every 2 months. And our treatment design is, for the time being, for as long as patient can tolerate or they do not progress from their disease. Our initial intention was to test if it's rather feasible at all to use biologics for frontline treatment, obviously with a mind, with a patient who are elderly or somewhat having multiple comorbidities who may not be suitable for chemotherapy. I would have to say that our preliminary results for this phase 2 study seems to be rather remarkable, because indeed it seems to be feasible, relatively safe, and quite active. For example, our overall response rate was over 85%, and a significant amount of patients, over 50%, could achieve complete remission. And the durability obviously would have to withstand the test of time. Majority of our patients are essentially over on average over 2 years on the study, so the median duration response has not been reached. So I think overall it seems to be rather encouraging and rather remarkable for a treatment regimen that is free of cytotoxic agents. Patients who are currently on study seems to have treatment-related side effects that are typical for what you would expect for exposure to lenalidomide and rituximab. And so those would include both hematological and non-hematological toxicities. The hematological toxicity, by and large, goes along with what you would expect for lenalidomide. And for the most part, they're asymptomatic. Patients do not require transfusion support. And we saw very rarely febrile neutropenia. So even though if they had cytopenias, those can easily be managed by treatment modification.